So I'm going to have a little model here. A couple things. One is your patient's anatomy is going to be unique. Only your patient will have the anatomy that you're seeing, right? And so, like for instance, in this model, these are gigantic, gigantic spinal processes, and hopefully most of your patients are going to have them that big. The other thing to think about is when you look for imaging, you're accessing here. Let me see if I can go from the correct side so you can see. You're accessing here, right? And some people talk about lining the disc space up. The disc space isn't really what our target is. Our target is the ligamentum flavum and in here. And so I don't get so obsessed with that until I want to figure out what level where I am. What I care about is being able to see how I'm going to get in. I've only seen the images that are on the screen here of this patient. I have no idea what this patient's anatomy is like. So that whole idea of planning and deciding if it's going to be difficult or easy, none of that has occurred. So I have no idea what we're going to find when we take a look here. The other thing is that for stability, if you're closer to T12, T11, L1, there's less movement of the spine. The leads are more stable during the trial. For access, down lower, often the spaces are a little bit bigger. So we're going to take a look and see what we have. I do not want to radiate myself. That's one of the first principles. I typically start on the far side, so I don't. Let's come up a little bit and see where we are. And I can see where we are. So I see a 12th rib up above, and I see that beautiful looking space just calling out for us. Spot. And Steve and I had a, go ahead. No, you don't need to move it. You're fine where you are. Okay, spot. You can come back down a little bit. That's fine. For this part, I want to be able to see where I am. Okay, spot. So I think that this is a pretty reasonable spot, location to go in for that space above. So make sure we're on the same page.
So he's aiming for this interlaminar space here.
Give me a spot. So I want to enter around here. And this cadaver is relatively thin. You guys probably can't tell that, of course, but it's a thinnish-looking person. So I don't think I need to go extremely more caudal, and this will be totally fine. So the patient is anesthetized already, very handily for us, so I don't have to worry about that step. And so I will now enter. Let me just give me a spot again to make sure I haven't moved something stupid. Okay, good. Spot. And spot. Spot again. Okay, so I'm going to come in a little bit more caudal than that. Enter and advance a little bit. Spot. So I ended up a little bit more lateral than I wanted to be, so I'm trying to readjust. Spot. And of course, the anatomy does not feel like I want it to, but we'll get there. It's interesting. Get a spot there. I'm pretty close to the space. Spot. I've fallen off. So that's a little bit more lateral than I usually wouldn't want to take, but it's what I've got. And I'm in the ligamentum flavum. If this doesn't work, we can always come back and reposition. If it was a patient, I would do something different, but I think it's important to kind of see what we get. So I've turned we can slide up a little bit, Steve, so the needle's now toward the bottom. Yeah. Okay. And spot. Good. So here we are. It's a little bit more lateral than I typically would want to be, but it'll be fine. So I like to advance towards the space. Make sure I have resistance, which I do, and you advance. This is not like a human, like a living person who's going to give you any feedback, and sometimes the feel of the tissues is different. But you saw that loss. Boom. Super easy to find a loss. Let's see what we got. Spot. So a little bit off to the side of midline. It's an acceptable location. Here's our electrode. There's a whole array of electrodes we could pick. So if we could show a side view to show the angle of the needle from the side to make sure, so they can see that it's not, not, okay. So it's a relatively shallow angle. So I have selected randomly, because I know nothing about the patient, of course, a 16 contact lead. I am going to advance it now until I feel like I'm towards the end of the needle. See what we have, spot. spot. So at this point, I'm going to go live. And the way that I do this is with my right hand, I adjust back here. So we can look at this. Yeah, adjust here. And I'm going to advance with this hand here. And we will go with pulsed fluoro, and let's go. So I'm advancing, and my goal is to kind of be towards midline. So I kind of come towards midline, shift. This is very floaty space. It's not providing much resistance at all. And let's stop for a second and kind of think where we are. So I'm at the top of T12, bottom of T11. And I'm going to try to, we'll see how far we can get and see what it's like as we go. Okay. Pulse. So here we go, a little obstruction. And I try to straighten it out so I stay close. I am sure it's deviating a little bit off to the right. So I want to come back and think about staying closer to midline. And back. And this is extremely not very realistic feeling, even though I know it is real. Let's stop for a second. So here we have I can see at this level, I can't really see the spinous process as clearly as I can above, but I can see exactly where I want to go. So I just want to make sure I'm planning where I am and thinking where I am now. So I'm at T10. Okay, here we go. Keep going. This is very much moving too easily.
So you can probably notice there's some changes to the curve of the lead. Sometimes the stylet will move back and forth. You notice Dr. Stacey's kind of flipping back and forth. That's very common. It's important to remember that the posterior aspect or the dorsal aspect of the epidural space is somewhat pyramidal. And so once you find that midline track, you'll find some patients where you can really just drive it straight up the midline very easily, and others where it's very flat.
Come down so the tip of the, yes, we can see where we are. And can you drop the C-arm down lower? Is this as low as it goes? Okay, we can bring the bed up a little bit too, so we can just kind of see where we are. Okay, and let's get a spot and see what we got. Okay. I'm doing this to get a nice wide image, a little higher up. Okay, come down just a touch. So we can see where we are. So 12, 11, 10, 9, which is the top of 8, okay? So this is a reasonable place to try someone. And I always start with the needle on the right side because I stand on the left. I want to not have to reach across my existing needle when I do the second one. So so that was the first lead. Any questions or comments or anything about that?
Any questions from anyone? So about 30 degrees off midline here, maybe a little bit less. If I were to be a perfectionist, and Dr. Stacey's already mentioned this, might have been just a little bit more medial.
Yes.
But his angle here looks excellent. Again, he's able to see, and we're not able to see. This is a fairly skinny patient, so he didn't have to come that far back in order to enter that space. But you can see a nice angle here. He's using a coude needle, which allows him to steer. So even if you're a little bit off, if you start out or the patient moves, he can recapture his appropriate angle by using that coude. In addition to the coude, you have a straight needle, but you also have a large curve TUI, which we can show you when we do the lab.
Okay. So let's come back down here and show me my entry spot for my next lead. I'll place another lead on the other side.
I'll mention that you can still come on the same
and
side.
Spot. Yeah, yeah, and I mentioned that in the trial thing. Sometimes if you're going to put 3 leads in, for instance, you can put 2 there and then go to the other side. And there is space here to do that. If you guys would like me to do that, I can do that instead. Would you rather me do that?
Whatever you like. But he has this nice path you see here, guys. You can just put Buddy up the...
Yeah, let's just do that. Let's just do it for fun. Okay, here we go. Just show me where I am, make sure it looks good. Come down here. Good. So you can see there's plenty of space. So I'm entering adjacent to that other one, and it will provide you with a nice path to follow. Spot?
What's nice is he already has that first QE in, so the coude, so he can just look at the angle and follow it, and just follow right next to it, and understands that he has
Spot?
about 4 millimeters of space to get right medial to it.
Spots? Spot.
So he's using the tip now. He can steer it left.
Yep. Spot.
This is a point where I really want to touch down on the lamina. Really
Yeah, which I just did. So I touched down on lamina, I felt it, and I just walked off. And I feel that I'm no longer on lamina. And I can see also a couple of things that give me all kinds of assurance. First is you can see in the picture that this needle's not as deep as the other one quite yet. That's nice and parallel. You can see that on the x-ray too. So I really can't be to the epidural space yet. I'm also not going to have to go very far to find the epidural space. So if I was really going to do a tripole with the 16 contact first, I would try to put that in the middle, and I would do flank it with 2 8s. But I'm not going to do that right here. We'll just do whatever lead I have loaded up. So there's nice resistance. I advance a little bit.
Another little tip I'll mention that when I touch down on the lamina itself, I'll inject local there because that periosteum can be pretty.
Yes. In a patient who's live, as soon as I touch, I tell them the whole time that until I get to the epidural space, I can put local anesthetic whenever you want it. So I'm totally happy doing that. So I should be really close because I'm seeing my angle. And there's the loss. So it's an incredibly easy to feel loss. I don't think our fellows have experienced that this year, a loss like that. So sometimes you're lucky with the patient you have. So if you look at the needles, they're nice and parallel to each other.
Stacey, we have a question. Just hold
Yes.
on a moment. Yes. Dr. Stacey, what would you do if you had a wet tap?
That is a great question. I would love to ask all the other faculty, and then I'll say what I do. When you guys talk in the room first, what you guys do?
So it depends on basically the severity of it. So if you created a paresthesia, you may want to abort completely and just say, we'll have to try this again another day and manage your post-meningeal puncture headache. I've had a situation working, with fellows at UCSF where we've seen, very slow CSF leaks where, I've informed the patient this is what's happening right now. If we can get the lead in by getting it appropriately in the epidural space and there wasn't a reason for that dural puncture besides technique, then we'll get the lead in the appropriate position and manage your post-meningeal puncture headache. If they're, very elderly, that risk is much less than if you had a 30-year-old woman, for example. So it really depends on the patient you're with, the severity of the CSF leak, and in my opinion, the level. But I'm sure you'll hear different things. A lot of people would say it's an automatic abort. That's the way I was trained, but I've been able to move forward, and as long as the patients are informed and you let them know what's going to happen, it'll be fine.
I have had a few dural punctures, and one of them has been me, and the others have been the people working with me. The one that was me was in Seattle. It was actually a patient I showed you. It was a patient with all that hardware. And it was an elderly patient with a low risk for getting a post-dural puncture headache. So I just basically changed to a new level. I assure that she has no other symptoms, no problems. I tell her what just happened. I tell her we have the option of stopping or proceeding, that most of the time that is not an obstruction to proceeding. I just go to the next level. So that's why I ended up with a needle lower than I wanted to because of that in that patient, because I was trying to avoid the puncture site. So let's put this other lead in. So I'm going to do the same thing, which I advance the lead until I feel like it's towards the tip of the needle. Let's get a spot, and you can, Steve, slide a little bit more cephalad. So I only want the tip of the needles at the bottom of the image, so if you can slide that way. Okay, spot. Good. So it's out, it's ready to go. Oh, one thing real quickly with this Coude needle, I'm going to bring this back in. Spot.
Hold on, Dr. Stacey, we have another question.
Yes.
Sure, you want to come back and see in lateral or in AP? Oh, sure, we can do the contralateral oblique, sure. So Dr. Stacey, can we get a contralateral oblique of the needles?
Yeah, sure. So give me an oblique over this way. An oblique view. oblique, so coming
So
like
a,
this.
a contralateral oblique view can be useful
Yep.
for helping, identify your epidural entry.
Keep going. Like
It's
a
a
lot
nice,
more like 30 degrees or something.
particularly, I use it particularly with cervical placement, just to ensure,
Yes.
obviously we're not going too far. I don't, I don't routinely use it for lumbar thoracic
Go a little
placement,
further.
but
So I don't routinely use it either. I use it if I'm having difficulty. And so I only use it if I feel like, hey, I'm a little bit lost. And then I will check a lateral at some point, depending on how things feel. If it feels like I've gone in a straight line and perfect, like you can see this lead is going in a nice, the first lead is going in a nice straight line. So the chance of it being anterior is extremely small. You should always at some point confirm that you're not where you don't think you are. So what I was going to say about the Coude needle, show me a spot, please, is that if you're going to adjust the bevel angle, you should never have the lead out because you can damage your lead. So you never want the lead out when you do that. So I'm going to turn the just for showing you how much of a difference it can make, I'm going to turn the bevel laterally, spot. You see how different it looks, and if I initially advance the lead, spot, you see where it went. If I come back in, turn the bevel the other way now, and give me a spot, just show me what it looks like, and advance here.
this is
I don't do anything, spot. It's a totally different position. And it ended up being perfectly midline, which you never know exactly where it's going to be. So the thing about stimulation, which I love, it's in the moment. You're advancing, you're moving. I tell fellows sometimes, charm that snake and make it go straight up. So you have to use a combination of what you see, your left hand, your right hand, the feel of, as you advance. There's a whole bunch of things together. Okay, live. Let me pulse.
what he said about turning that needle is an extremely important point because you might get away with it and not think there's any damage. Your lead looks, perfectly intact, but you could be stripping the insulation from that lead. And if you think you have an MRI conditional system and then they get an MRI because you think you've met all the conditions, that's problematic. You could have thermal damage.
Be nice to that. You want these leads to last years and years and years, decades, right? So really be nice to them.
Be nice.
Especially when you're doing the permanent implant.
So it's nice now when you have your second lead, you can run it basically along the track of the first lead.
And as I'm advancing, there's a couple places where there's a little bit of obstruction. We can stop, and it just won't go. And then I just kind of give a little bit of extra pressure and provide a little twist here, and then it goes. Okay, live again. Pulse again. So sometimes, so this is like a stop. The curve in this is not necessarily our friend right now because it's oversteering. So you might, if you're having difficulty getting it to go straight, switch to a stylet that's less curved at this point. Pulsed again. So I just want to bring it up. I went really slow. Stop. And then the other thing I do is I pull the stylet back, typically at this point, and spot to see how the leads move when you pull the stylets back. Because sometimes they flip, so the orientation of the top part of the lead, changes by a fair bit. Let's just, how much time do we have left? A few minutes.
Few minutes.
Good. Let's just put another lead in so we can put 3 in for fun, and let's pick a different location to go in just for variety. Show me a spot here.
Any questions while he's starting to put in the, yes.
Spot.
Do so if you have concerns. What Dr. Stacey is, I'm reading his mind, obviously, but he has a feel for what he's doing. And, generally as you get more adept with this, you will know if you're heading post or ventral or not. Secondly, with that CLO we knew we were posterior, just seeing it wrapping up behind the lamina as you go up. So we've already sort of confirmed that, but we will check a lateral for sure before we're done.
Yeah, and when I put the third lead in, we'll check a lateral. So a couple things I want to make about this level, because the space is not as clearly visualized. So we could adjust angles. We can adjust the C-arm and see if it looks any prettier. Bring it back this way, so a few degrees. Just try there, spot. You can go back the other way. The disc space looks beautiful, spot. It's not a huge difference anyway, so come back just a straight. So try to make it look good, and I usually pick a space I can see well. I can't see the space very well, but we're going to, for purposes of playing, we're going to try this spot. Okay, so I've anesthetized the patient's skin. I'm a little bit more cephalid than I usually would be. Spot again.
You get an osteoporotic 80 to 100-year-olds, you're often going to see images like this where the lamina really
Spot.
cannot blow up at you.
Yeah.
So you're going to trust your feel and the approximations of your other landmarks. Like
So if you saw what I just did there, I moved the needle more medially because I thought I was starting too laterally. So I just pulled the whole thing more medial. Spot. And this is very crunchy. That's my feedback. It's very crunchy. Spot. And I'm on lamina very firmly here. Again, I would completely agree with the comment about putting local anesthetic here. It's an important place to put it. And then advance. Spot. And see where we are. And move. And I just felt myself walk off. Spot. It looks like I should have walked off before, but I really feel it now. And we'll go again. Now, one thing, this is a more shallow angle this time. So with one thing I like about the coude, sometimes you will overshoot the space if your angle is too shallow. So you can always aim the bevel down initially, so you're diving into the space if you need to. I typically don't do that to start with, but if I find like I've overshot, I will come back and do that. So I often will lift the needle up, though, as I advance. So I'm going to advance just in feel. So this space already has a very no resistance feel to it. Awesome. So no real resistance to start with. Spot. Even though clearly I'm not in the epidural space, and I pulled back. So there's resistance. Spot. Okay.
I'll mention a few things about fluoro. It's really important as you saw.
So there's the loss.
You work with your fluorotechs
Spot.
intimately. They can make or break you.
Slide a little bit north.
I will collimate quite a bit.
Oh, yeah.
To help with your visualization and to reduce exposure.
So we have the luxury at the pain clinic of having a Lura machine, which can be a CT scanner too. It's a ridiculous overkill for 99% of our cases, but it is beautiful, spectacular images. If you spend 10 times as much, you get a little bit better machine, turns out. And we collimate all the time. So I don't really need to see all those ribs out there and stuff, but I don't care at the moment because we're going to just get things done. Spot. So I feel like I'm towards the tip, which you can see, and we're going to go with a pulse.
So he's asking for pulse also to reduce his exposure.
And you can also use some systems have what's called low dose, so you can do a lot of different ways of minimizing the radiation to you, the people in the room, and the patient. So this is going to go nice and fast and easy. But in general, if it's not going perfectly, go slower, right? So I'm just going to bring this up and pull the stylet out, and those are a little bit too close for me, so I don't like that. So we're going to move a little bit. Pulse again. I'll move a little bit more lateral just for fun, maybe.
Yes, please.
There it goes. And now I'm going to pull it back down into position.
You want to be careful about it, but truth be told, if you have a forgiving epidural space, you can bump it, and it's okay.
Okay.
But be careful. I mean, try not to, stab clearly.
So a couple things. This is moving way easier than 90% of your patients. So this is a, when I knew I was going to do a live demonstration, of course I had this image of the impossible to advance catheter and the arachnoiditis kind of patient or something. This is not that patient. This is very, very easy to advance. The dura is more vulnerable to your needle than to anything else, and then to the lead. The lead blank that you might use sometimes if you're not sure if you're there, which I don't have one here, but if you use a lead blank, that is stiffer than your lead, and you can poke through the dura with that. I've seen that, unfortunately, so not a pleasant thing. So I would usually move this image to the right screen and get a lateral view.
So you might want to create a beautiful lead configuration and have symmetry and all that. Doesn't matter. What matters is the patient's perception. So, Brett already showed some images from his lecture where the leads, you could judge them. You might think, oh, they're not symmetric, or that Infineon lead is not midline. Maybe it should be midline. It doesn't matter. If his lead configuration works for this patient, that's what's most important.
So got something interesting. So go up to where the contacts are.
So nice posterior placement. You can see the vertebral bodies here, the neuroforamina, and then your nice posterior placement. All those three leads are in the same plane there. And what you'll generally notice is the tips may be offset just slightly, and that has to do with whether they're in the certain part of the pyramidal tract.
And if you
remove the style.
can you swap sides? Okay. I'm going to rely on your memory. Actually, let's move that to the right. So look at that one contact that's a little bit more anterior, just slightly more anterior. Come back up. You could have predicted that by looking at the AP view, where that contact is kind of aiming off to the side a little bit. But in general, if you
want to go over, let's say that the leads were not in the dorsal space, what approach would you take right away?
So pull it back. Take the lead out. This is what I would do. Spot. Yeah. I would take it out.
Okay.
And then I'd go back and look at my needle spot, my needle entry location, and decide if I needed to do something different. And that could be using the same skin entry, pull back a little bit and change the trajectory so you enter more medially or something a little bit different with the entry into the epidural space. Or if it feels like right away the lead was kind of taking a meandering path, I would try it again, maybe turning the tip of the needle and angling such that I try to avoid that getting off course path we took at the beginning.
Okay. Have you used other techniques where you're in the lateral position and seeing if you can reorient it to the dorsal space? And that's been helpful to my practice.
It also depends on how easy it was to get there. In this case, it was super duper easy. So if you're not perfect, make it perfect, right? If we spent an hour to get to this point, I'm not going to just randomly rip the lead back out and put it back in again. I would really do it quite differently. So it depends on the scenario a little bit. Okay, spot.
For the fellows, I do want to make a couple points.
A little bit lower.
During the trial is
it's good.
Is looking at this from a.
So back up a little bit. I'm sorry.
So that every time you're looking at and approaching the patient and measuring, well, how big is the interlaminar space? And measuring how far down below should you enter with the needle. And a lot of different courses that you'll come across will, they say, a vertebral body and a half, and maybe entering at an angle of 30 degrees above horizontal. It's going to be personal preference and, of course, how large the space is and how acute that angle is into the space. But a few markers, a few things to think about are, a vertebral body and a half below the interlaminar space and 30 degrees above horizontal is something to kind of think about while you're approaching the patient.
So if you can't quite see my needles in here, but they are a nice shallow angle. The other thing to notice is that I started at basically the same area based upon bony landmarks for the three. But as you go more cephalad, there's less tissue here. So down here, there's down in the lower lumbar area, if that's where you end up accessing, there's more tissue to go through than there is up here, especially in this patient who has, my finger is below the level of the spinous process in the paravertebral space here. So I'm going to advance this lead up again, and then I think we'll call this good. Okay.
You should also note your products. So he used an Infineon lead, the 16 contact lead with Boston Scientific.
Okay.
It is a stiffer lead. Because it has to have 16 wires through each contact twirling all the way up that lead. It's the same diameter, the same materials, but it's stiffer. So you may end up being a little bit you might end up entering maybe 2 vertebral bodies below, so you have a very shallow angle to get in, okay? If you are coming in greater than 30 degrees or 45 degrees, you're just going to be bumping dura. You're not going to be able to get it to advance into the space. So Brett uses the coude, which helps shallow that angle as he gets into the epidural space, so that lead has a nice curve as it goes in. That's one of the advantages to a coude or large curve TUI.
I just put
But
something.
again, if you're good with a straight TUI, that's totally fine. There's nothing wrong with that. Just understand those angles and how important they are for your success.
So this is going to be a fun cadaver to play with because it's so easy to steer stuff, and you can, if you put the leads like this and the patient told you, it's not getting down, you could always easily move these more lateral. And when we do the sessions this afternoon, we'll play around altering the position within the epidural space and trying to go more lateral some of the time and try to be right in the midline some of the time, just for variety.
This looks like one of the best cadavers I've seen, actually. So I think we're going to have fun.
Thank you, whoever picked this one for me. I appreciate that.